Ma'am, should we start? Ruchi ma'am, Priyanka ma'am.
Hi, Dr. Neha.
Hi ma'am.
I'm ready. Yes, Neha.
Okay,
You can.
Okay,
Yeah.
ma'am.
Good morning,
Good
Ruchi.
morning, everyone. Welcome to the day 5 of the Oral Hygiene webinar series. Today's lecture is by Dr. Ruchi Bantia, and she would be speaking on COVID and mucosal lesions. And chairing the session today is Dr. Priyanka Jaiswal. She has completed her BDS from VSPM Dental College, Nagpur, and post-graduation from Sharad Pawar Dental College, Wardha. She has also done her PhD and MPhil from Sharad Pawar Dental College, Wardha. She is currently working as professor in the Department of Periodontics in the same institute. She has published over 60 research papers and 2 monographs in national and international journals and has more than 10 copyrights to her credit. Over to you, Priyanka ma'am.
Thank you, Neha. First of all, I take this opportunity to thank Dr. Shureka Rathor ma'am and whole team of VSPM Dental College for organizing this series of webinar and choosing the topic which are really insightful. It's my great privilege to introduce Dr. Ruchi Banthia ma'am. Dr. Ruchi Banthia ma'am has completed her graduation and post-graduation from Punjab Government Dental College and Hospital, Amritsar. Madam is currently working as a professor in Department of Periodontic in Modern Dental College, Indore. She has 21 years of teaching experience. There are many national and international publications on her credit. She has presented many papers and have won various awards in paper presentation and essay writing. Ma'am will be delivering a presentation on topic COVID and mucosal lesion. COVID-19 has widely affected the mankind. It has its impact not over only on the respiratory system, but it has affected the immune system as well. It had impact on oral and perioral tissue also, resulting into development of erythematous plaque, ulcer, blister, bullae, petechiae, mucositis, and discomitative gingivitis, etc. To know more in detail, I would like to invite Dr. Ruchi Banthia ma'am to deliberate on today's topic of webinar, that is COVID and mucosal lesion. Over to you, Dr. Ruchi ma'am.
Thank you, Priyanka ma'am, for a wonderful introduction. And first of all, my gratitude goes to all the team of VSPM, Kolte sir, Surekha ma'am, Neha, and all the others who are behind the scenes. And I know you all have organized a very good series of lectures. And this is step by step we are progressing towards the celebration of Oral Hygiene Day. So a lot of good topics have been covered. So this is slightly different topic. Why I chose this topic? I had various reasons. See, more and more number of patients are reporting with such lesions. So there is so much increasing incidence. See, we have been in practice for so many years. We are seeing a lot of patients who are having ulcers, blisters, autoimmune diseases. But suddenly there is a surge in the incidence of these lesions. And the lesions have been much severer as compared to the earlier phase, non-COVID phase, we should call it. Then there were so many patients who just presented with the lesions. And when we just suddenly got them checked or RT-PCR was done, they were found to be COVID positive. And see, we all are very good. We always maintain sterilization. We have been very good for that. But slowly, all the practitioners, they had become very casual about the sterilization. And this COVID, has moved every one of us. And all the principles which we already have been following, they have been revised. They have been reinforced. So that's why just to, wake up ignored medical professionals that this is risky because stakes are really high. It is not a simple virus which is coming and going. It is causing much side effects, which we are not able to know right now. I don't know what the future holds for us. So we have very high stakes in that. So this topic was chosen to, highlight all these things. The oral mucosal lesions, they are very important to know, because see, as a periodontist, we are seeing gingivitis, we are seeing periodontitis, we are seeing periodontal lesions. But when I just came across so many patients with oral mucosal lesions, so these all, what I'm going to tell you in this slide, these all were like, they just struck my mind that most of them were the signs of latent coronavirus disease. Means some people were not knowing only that they are having COVID and they are presenting with these lesions. In some patients, after few days, systemic diseases, that is the symptoms, this lung symptoms of COVID, they precipitated. As Sir William Osler has rightly said, that oral cavity is the mirror of systemic diseases, and suddenly these mucosal lesions are proving that right, even in this today's scenario. So there was co-pathogen hypothesis also. That means that this COVID virus, what it has done, it has waken up all the hidden viruses, latent viruses, or the microorganisms which we used to think they are our friends, they are commensals, they don't cause us any harm, but it has actually caused them to get activated or reactivated. So a lot of lesions have been the result of co-pathogens. Then we all know that even the lay persons now, they know what is cytokine storm. Many people were having so many complications. So they used to say that there are so many cytokines. We took so much effort to teach our students host response, interleukin 1, 6, and tumor necrosis factor alpha. But suddenly COVID has made it so simple for everybody. My all patients, they come and tell, ma'am, hame cytokine storm ho gaya tha. Like, they all know this term. And for us, it is very important, because back in our minds, I think we have stopped revising our immunology, and this COVID has revised everything for us. So this immune dysregulation is a very important cause of oral mucosal lesions. Then there is a network hypothesis. I'll come to this in the next slide. This is actually, we all know everything about immunology. When I talk to my medical friends, they always say, yeah, this concept is always there. Yeah, concept is there, but we, stopped highlighting that concept. We stopped using those concepts to diagnose our lesions. So network hypothesis, which is refabricated, you can say, or rejuvenated. And this I will come in like next slide. And whatever oral mucosal lesions have been seen, they may or may not be just the result of COVID virus itself or the resultant host response. It might be like, now we all are vaccinated with almost 3 doses, booster dose also. So there might be rare adverse effects of these vaccines. So I don't want to dishearten the vaccines, because see, there are always risk versus benefits. But there might be certain side effects which might be associated with the vaccines which we are taking. So we all know that COVID, this SARS-CoV-2 virus, it enters in our body through ACE2 receptors. So whatever symptoms have been, I will be discussing in oral mucosal lesions. So one of the factors is that all these oral tissues are very rich in ACE2 receptors and TMP-RSS. So all the oral mucosal, चाहे pharynx हो, larynx हो, oral mucosa हो, nerves हो, salivary glands, they all are rich in ACE2 receptors. So this is a very important diagram. Sorry, thoda sa, I have drawn it myself. This is a virus. We all know that we are representing the spike proteins like this. This one. So they come to our antigen presenting cells like macrophages or dendritic cells, and they interact with the receptor binding domains. So this antigen presenting cell now holds on its body the spike protein configuration. So then naive T cells they come into picture, and we all know that there are 2 pathways, T helper cell 2 pathway and 1 pathway. T helper cell 1 pathway goes to the cytokines and interferons. Okay. So cytokine storm happens and many complications happen because of that. But oral mucosal lesions, most of them have been found to be because of Th2 pathway, where Th2 in presence of interleukin 4 and 5, they activate B cells, which get converted to plasma cells, and then they form antibodies. So most of the oral mucosal lesions are related to antibodies. So network hypothesis. See, Neil Jern is a Nobel laureate. He said that what happens is when SARS-CoV-2 binds with the macrophages or antigen presenting cells, I have already discussed, they present with the spike protein configuration. Our body by following Th2 pathway produces antibodies, and these antibodies are against the antigen. We call them as idiotype antibodies. So see, it is not clear that what happens to these antibodies will definitely attack antigen, and there will be neutralization of antigen, or sometimes, you know, antigen skips these antibodies. But in certain individuals, which they have not made very clear, but they cell maybe because of B cell hypersomatic mutations, in certain individuals only, these antibodies suddenly they start acting antigens, and body starts producing antibodies against antibodies. So antibodies against antibodies are known as anti-idiotype antibodies. So these antibodies are responsible for all the autoimmune reactions. See, this is the spike protein. Against this, we have produced antibodies. But against these antibodies, body is again producing antibodies. So antibody against antibody will have same configuration as spike proteins. So that is why in certain individuals, even though RT-PCR comes negative, there is no, you know, stoppage of symptoms. Symptoms start getting lingered on. We call them as long hauling. And Murphy and Long, they have said that this is the mechanism responsible for side effects after vaccination also, that antibody enhanced reactions. So now I come to oral mucosal lesions. There are so many. The most common ones, see, this is like what I have seen in my clinical practice. I started looking for, a lot of these symptoms. I have called a lot of friends to share certain pictures with me. So I found that herpetic lesions were the commonest one, then Zosteriform lesions, stomatitis, hemorrhagic ulcers, even neurological symptoms, mucormycosis, then autoimmune diseases. See, they were always there, but suddenly, you know, there is surge in the patients. Like हमने जैसे case देखा, mucormycosis के cases were never seen. I have never seen in my, you know, career, in my medical college posting, I have never heard of this mucormycosis. Then so much stomatitis, you know, every patient, most of the patients are coming with stomatitis. Suddenly, you know, you start feeling what is happening. A lot of people are coming, then necrotizing diseases, osteomyelitis, then ageusia, loss of taste, glossitis, Kawasaki, lot of lesions are there. So these patients, they were found to have associated histories also. Like not all patients were asymptomatic. Some patients gave the history of fever 1 week back, some gave 3 weeks back. And, you know, many patients were in fever when we checked, when they presented with the symptom. So they say that interleukin-6 is a pyrogenic interleukin, and that is responsible for these lesions. So this is by Arbas et al. Then the patients were also having muscle pains, weaknesses, and then associated skin lesions were also very common. See, 61% is a very high percentage. So lot of patients are having skin lesions. See, one by one, we will be discussing underlying mechanisms of these oral lesions. First of all, I have already discussed that ACE2 and TMPRSS2, transmembrane protein receptor serine 2. ये सारे receptors क्या हैं? They are very, very common in oral mucosa. They're very common in salivary glands. So they make these portal of entry as well as the vulnerable sites for lesions. So that is why oral mucosal lesions are very, very common. So as we all know that when the salivary glands get affected, they produce salivary IgA, which is a defense mechanism in our oral cavity. So reduction of this salivary IgA may cause a compromised defense, and then super infections may occur. Then there is immune dysregulation. We are already talked about, you know, cytokine storms. Then very important, see, when this virus came, everybody thought that it is, you know, causing some edema in the pulmonary tissues. And when the autopsies were performed, they came to know that there were vascular changes. So they call it as a vascular virus or vasculopathy virus or thrombopathic virus, they call it. So that means that thrombotic mechanisms of the body. So when there are thrombotic patches, there are clot formations. See, we all know that a lot of young patients, they are coming with myocardial symptoms. They are coming with heart attacks. Suddenly, I was reading a report in newspaper 3-4 days back that they say that earlier the incidence of heart attacks were 2 to 3% in young people, but now less than 35 age group is having 26% incidence. Means itne sare log hain, itne sare young people, they are suffering from these thrombotic episodes, though they are not directly linking it to virus, but virus may be a very important cause. So like we, earlier we used to do equation 1, equation 2, and then A is equal to C, B is equal to C, so A is equal to B. So we have this, thrombotic thing in mind, that this is very important, especially because we know that whenever there is a clot, there'll be ischemia, there'll be oxygen deprivation, and then there'll be necrosis. So necrosis will cause a break in the continuity of epithelial membrane, and what we call it as ulcers. So then, mask effect. We have never worn, masks regularly. We have always wearing while doing patients, but regularly for 24 hours for every, like except for sleeping, you are always wearing mask whenever you're going out. So mouth breathing, dryness of mucosa, they might be one of the reason that why these angular cheilitis or dryness of lips or cracked lips, they are becoming common. So we all know, see, even I suffered from COVID, and what happened, I was not having too many symptoms. I was having mild fever, and slightly my oxygen went down. There was no, I didn't go to any hospital. It was like cured at home only, but I had severe weakness and I was not able to eat anything. So low intake of fluid and nutrients, malnutrition is also one of the reasons. A patient आता है हमारे पास, हम बोलते हैं कि अच्छा, okay, after ulcers are there, or they may be because of, see, give them vitamins, give them, this is a routine, this thing, we are giving zinc, we are giving sprouts, we are giving good nutrition. So low intake of fluid and nutrient might be one of the reasons that why these lesions are becoming common and common. See, we have seen one patient who was presenting with bleeding gums. So thrombocytopenia, everybody feels ki thrombocytopenia, even platelets were low in number, and we started doubting whether the patient is having dengue. But then RT-PCR came out to be positive, and they say that this thrombocytopenia may be because of the excessive thrombosis in the body, which has used all the platelets and all the coagulation factors, that is DIC-like stage might happen. But this patient was not having that severe symptoms. But then he was cured he was given medicines for COVID, whatever, like he was admitted, then blood was given. So he recovered. So thrombocytopenia can be one of the reasons. So that is why we are seeking a lot of petechiae, a lot of bleeding things. Then anxiety and stress. See, everybody, this is a new virus, and everybody is under extreme psychological stress. We have lost so many near and dear ones. Suddenly, there is, we feel lack of services. Like the log zyada hain, medical facilities are very less as compared to, we are so many in India. The population is really very high, second most populous country in the world. So we didn't, the per capita resources, they felt deficient. So that anxiety, that stress, that what will happen to us, what will be the future, kids ko leke, like for the what will happen in the future. Lot of theories were there, so a lot of news. So that precipitated anxiety and psychological stress, and that might be one of the reasons. Corticosteroids are being secreted, so they all cause. Then noradrenaline, adrenaline are secreted, vasoconstrictions, they might be the cause of ulcer. Then drug reactions. See, a lot of drugs are being given. Patient COVID ka hai, to itna lamba drug ka prescription hai. So that prescription is having so many drugs. See, I have never, I was searching remdesivir. मुझे वो मिला ही नहीं, मतलब Google, because it was not FDA approved that time when we started giving it. Then remdesivir was talk of the town. Then tocilizumab. My all non-medical friends were talking about these drugs like it was so easy, but I took so much time to remember it. So might be these drugs are causing reactions. Or as I have already told, that there might be opportunistic infections because we are giving so many antibiotics. Azithro bhi de do, doxy bhi de do. So many opportunistic infections are there. Then very important point, that virus causes disruption of cranial nerves, peripheral nerves, and supporting cells of neural transmission. So that means we might have direct neuropathic effect, like we have ageusia, we have anosmia, okay, taste nahi aa raha hai, smell nahi aa raha. Like for me, there was like smell was okay, but I felt ageusia. Like मुझे काफी time तक taste नहीं आ रहा था, but after 15 days I had anosmia and the taste was normal. So very unpredictable symptoms. Then there are autoimmune reactions. We have already talked, anti-EDO type antibodies. So that means antibodies against your, see, autoimmune means body's own tissues are being phaged by the antibodies. Like we are making antibodies against our own cells, own tissues. But suddenly, antibodies against antibodies, these Murphy and Longo, what they have done is they have detected the anti-idiotype antibodies in certain people who were long haulers or who were having severe vaccine side effects. For in their serum, they detected these anti-idiotype antibodies. So autoimmune reaction is against the tissue, and anti-idiotype antibody is antibody against antibody. So then I have already talked about fever, that pyogenic cytokines like interleukin-6, they can, what they can do, they can reactivate the latent viruses in the sensory ganglia. We all know that like our herpetic virus stays, first it causes disease in oral cavity, then it enjoys our stay in sensory ganglia, it transfers through peripheral nerves and goes in the brain and stays there, for lifetime. But then suddenly the resistance goes down, or certain cytokines are released which reactivate them, and they are good to go. They again cause lesions in our oral cavity. Then viral shedding of saliva, like see, body is having virus and virus, serum mein hai, har jagah hai, tissues mein hai, because ACE2 receptors are everywhere. So suddenly lot of viral shedding is occurring in saliva, and lot of this sudden viral load has been increased. This might be one of the reasons for development of these oral lesions. So now if I come to sites of mucosal lesions, like see various authors like Iran Mesh has said tongue, लेकिन बहुत सारे दूसरे authors हैं जो Shanmir है, बहुत सारे authors I have given in my references, उनके लिए tongue was the main site. Like 38% इसमें है, 43% किसी में 27%. Tongue was the main site, followed by labial mucosa and palate. But in certain studies, palate took labial mucosa. Palatal lesions were much more common than labial mucosa. But what we have seen in our clinical scenario, labial mucosa was the number one. Like lot of lesions on labial mucosa we got, and stomatitis. We had few tongue lesions, and palate के लिए सिर्फ एक या दो patients हमें मिले, right? So because see, we have not reported right now because उतना सोचा नहीं, it just struck us कि हो क्या रहा है. Like every day lot of patients are coming. ऐसा कभी नहीं हुआ कि I have seen only one case of herpes zoster in my career, मतलब जिसमें oral signs and symptoms थे, mandibular nerve was involved, maxillary nerve was involved, but suddenly my mother, my बुआ, my auntie, एक हमारे यहाँ एनाटॉमी के टीचर थे, वो बहुत सारे लोगों को हर्पीज जोस्टर हो रहा है, और हर्पीज जोस्टर इज लाइक चिकन पॉक्स वायरस की लाइफ में एक ही बार होगा, है ना, ऐसा बोलते थे. लेकिन सडनली माय मदर हैज गॉट इट ट्वाइस, बुआ हैज गॉट इट, लाइक ऑफ्थेल्मिक नर्व, मैक्सिलरी, मैंडिबुलर, तीनों इन्वॉल्व हैं. लाइक सो लॉट ऑफ दो दे डू नॉट हैव म्यूकोजल लीजन्स, मुंह में उतने अल्सर्स नहीं मिले, उनको नहीं दिखे, लेकिन इट इज वेरी पेनफुल. सो suddenly the surge in such cases, and already the people who had herpes zoster, they are having it on some other sites. Now I'll start lesions one by one. If I just say that because the commonest we saw was tongue in the literature, and as an academician we have to respect scientific literature, so my literature says that tongue is the most common one. So if we just talk about COVID tongue, it is a term which was given to the tongue lesions in the COVID patients. So like they have a strawberry-like tongue. See, bumpy. Just a minute. See, like this. Like this. This is like strawberry tongue. See, then there was geographical tongue. Then there was there was macroglossia also. See, many people, they say that because of the lymphatic blockage, because we are putting the patient in prone position, so that is causing the blockade in the lymphatic spread, or there are malformation of lymphatic vessels which is causing the macroglossia. See, I did not, I was just telling my students why we are seeing so many cases of tongue thrusting nowadays. I really don't know whether there is some connection or not. We need so much literature to prove this fact, but a clinical finding that a lot of people are coming with tongue thrusting, gaps in the teeth, then edge-to-edge bite, and then open bite also. They say कि पहले नहीं था, and then suddenly you see the indentations on their tongue, and you feel like tongue is like size is increased. So even geographical tongue, there bilateral depapillation or random depapillation of tongue, this has been observed. See, all these might sound very routine findings. We feel here we have seen this is, but as they are the signs of latent latent COVID infection. So, I think it needs some thought process or some, just stop there, and because the stakes are very high and we don't want that it should spread, like it should be a visport, or it should be like a lot of cases suddenly come, and we have to protect ourselves also. So mouth ulcers, as I said, like we have seen, many of these photographs have been taken from net, ma'am, because few of my friends have, sent their cases for publication. So though they have sent me their pics, few have not sent that. I'll be, this sharing directly, but few I have taken from net, because many people, they have sent it for publication. So they have requested that I should not show those photographs. So I'm not showing, I have taken this from net. So after sir, I've already talked about that, stress is there, anxiety is there. And one thing which is coming up is lot of people were giving steroids. The prescription which was given to me also had steroids. So steroid is a very important this thing. So then we are giving any antimicrobial, like candidal infections are there. So we may say that they are white candidal lesions, or they are ulcers. There are ulcers on the tongue also. Then herpetiform lesions. See, these, like I think in like per day we are seeing 3 or 4 cases of this herpetic labialis lesions. Shanshal and Ahmed, they have said ki they have seen that these herpetiform lesions were much more in incidence, as well as much more severer form was there as compared to the known COVID patients. Like they say that almost 78% people, they had single attack of lesion. Then around 14% who have double attack, ki baar aaya, 2 baar aaya, 3 baar aaya, around 7%. So all these cases, they have been again and again, they are occurring. There is canker sore, like this is crusting, this is at healing stage. Then there are multiple vesicles, multiple ulcers. So much more severer attacks in almost 43% patients as compared to the known COVID patients. Most of these patients, were having COVID. They had fever that time, or they had a fever in 2 to 3 days back. So RT-PCR came positive for few of our patients. If I talk about pathogenesis of these lesions, these herpetiform lesions, then there are direct neuronal effect. That means that I've already talked that this virus goes and stay latent. And when the lytic stage is coming, when the reactivation of this virus is occurring, there is a lytic stage and it is becoming active. Then fever, malnutrition, then immune dysregulation, then stress. Stress is a very, very important factor, like catecholamines and glucocorticoids. I've already told you that catecholamines, there's a vasoconstriction, blood supply to the area is decreased. Then glucocorticoids, they are immunosuppressive drugs. So there is immune suppression is very important. Your immune system has been surveying it. There was an immune surveillance against this latent virus. So that is why the virus was localized in the sensory ganglia. But suddenly immune suppression or immune dysregulation has occurred, which has led to, the precipitation of these lesions. These are the Zosteriform lesions. See, there might be double or triple attacks. I have already told you that there are changing trends. हमने आज तक पढ़ा, हमारी इम्यूनोलॉजी के नॉलेज थोड़ा थोड़ा चेंज हो रहा है. लाइक हमने पढ़ा कि जो चिकन पॉक्स वायरस है, बहुत रेयर पेशेंट्स में होता है कि इट रीअपियर्स. See, this is varicella zoster. So patients are getting, like 3 of, I told you, my known people who have got these lesions. So most of these patients were never knowing that they were either having COVID or not. Like my mother was tested positive once, but others I have not known, only because they don't want to get it checked. No, we don't have any symptoms. So these were like these Zosteriform lesions. And when my mother got it for the first time, it healed in around 26 days, or you can say 1 month. But when like this time, almost after 2.5 months, she's not completely got rid of these lesions. It is like there is so much swelling, there are so much numbness, there is so much, like neuralgia has also started, like severe burning, sharp shooting pain in thigh. My mother has got. Sites are different. Pehle mama ko gale mein hua tha, abhi she has gotten on thigh. So the lesion is not healing, it is creating so much trouble. So lesions are same, but their progress is different, their course is different, their severity is different. This is like Kawasaki-like disease. This we have not seen, except for, like, I've seen so many patients with red eyes. So red eyes might, and then there was this tongue glossitis. Then these symptoms were very common, and I just came through one lecture that they said that Kawasaki disease-like symptoms are there, because especially in children they were found having, they found coronary artery aneurysms. Sorry for this, my expertise is not there. I have not seen and I've not followed such cases, but I've seen peeling of skin. I have seen this in my one of the patients, but I was not knowing that it is Kawasaki's disease. In the hindsight, when I just prepared this lecture, I came to know that itne sare rashes or jo skin peel off ho raha tha us bacche mein, and red eyes were there, strawberry tongue. Like, we were not able to know that it was, this COVID-related symptom. Then I talked about petechial spots, hemorrhages, ecchymosis. See, there is distal ischemia or microvascular angiopathy or thrombocytopenia. They all are leading to these petechial spots or purpuras. These are my autoimmune diseases. Like we all know pemphigus, lichen planus, they were already there. Like we have seen in oral paths, we have seen in during the regular course of our practice, we see such cases. But like one or two patients I have seen for lichen planus and one for pemphigus. It was such a severe flare up. I mean, I was like, they were not responding to steroids. So what is the reason? Like why autoimmune diseases are becoming so severe, or they are not responding? Maybe one of the reasons, maybe steroids were given, then they were withdrawn like 5 days, 10 days, and very high doses of steroids have been given, to these patients. So maybe the withdrawal symptoms have causing them to flare up so much. So there are some other reasons for autoimmune reactions also, like, when spike protein comes and your macrophage binds it through RBD. So certain conformational changes or internal signaling, it changes in, macrophage. So sudden overactivation of complement system and, body's own cells, against all body's own cells, antibodies are formed. There are disruption of the ACE2 receptor functions. So we all know, ACE2 receptor karta kya hai basically, hai na? Ye karta hai ki there is a balance between anti-inflammatory and pro-inflammatory properties or responses in the body. So that balance gets disrupted and severe inflammatory responses there. And body, why we say these are autoimmune reactions? Because suddenly when we give high doses of steroids, they were helping. See, flare up was there. When you give only topical steroids, normally, I have seen patients who have, got very good results with Trioplast. It's 1% triamcinolone. But now there is no, they don't actually respond. But then we took dermatological help and high doses of steroids were given. But I really wonder whether a vicious cycle will set in or whether those patients will be relieved of the problem. I really wonder. I really wish that patient theek ho jaye, because you cannot see them in so much pain and and they don't know what has caused them this. And very young patients, they are having such autoimmune reactions. And all these drugs which were given, they have lichenoid-like reactions. So lichenoid-like reactions are same. See, for histopathology, they are different. But pain to wahi hai. Our quality of life is also getting compromised, and patient is not getting relief properly. Like with this, like they have to be given, so much steroids. But yes, they are. Good part is that they are responding to systemic steroids. We need to be very vigilant about these cases. So like mucositis and stomatitis, we see a lot of patients, even necrotizing ulcerative periodontitis lesions. We all know that distal ischemia is there. I have talked about it. Thrombosis ho jata hai. There is like lack of blood supply. So they might be, that is one of the reasons. Or there is superinfection with P. intermedia. There is superinfection with Treponema denticola. They have seen that these bacteria were like in very, very high number. So these mucositis, stomatitis, they may, represent enhanced immune reactions of the body to the virus or to the bacteria, or it might be because of the superinfections. Then coming to dry mouth or xerostomia, I thought that I should take one slide for this also, because many candidal infections, we all know, they are because of xerostomia. So salivary glands, being rich in AS2 and TMP, RSS2, they get affected. Then they get inflamed. So they produce less saliva. Sometimes, there is over salivation, but that is a very thick and ropey saliva. Then most of the times, because salivary glands cells, they die. So that leads to xerostomia. That is like loss of taste also has been, xerostomia is also one of the cause of ageusia. I'll be taking, one or two slides to explain ageusia and dysgeusia, because we are seeing a lot of patients right now. After COVID, like 3 months, 4 months after COVID, also their taste sensations and anosmia has not gone. So that is, causing so many things. They are like not able to enjoy food, quality of life is different. Then they are, biting their tongue, like they are not able to smell properly. So they are taking rotten foods. Sometimes one patient of that, she said कि मुझे पता ही नहीं चला मैंने पुराना खाना खाया. Like she had severe gastroenteritis. So all these symptoms are there and they need our attention. So taste alterations, or we talk about gustatory disorders. This is very, very important because most of the patients, especially जो mild or moderate cases थे, उनमें ना taste alterations were there during the COVID. Like मुझे ऐसा लगा कि I just got this taste alteration after COVID. I had anosmia during COVID, like all the 14 days of COVID, I had severe anosmia. So, but there are three types if we talk about taste alterations. One is dysgeusia. Dysgeusia means qualitative alteration of taste. Like बहुत सारे लोग बोलते हैं कि common cold is also having, all आपको तब भी तो खाना स्वाद नहीं लगता है ना. You also, so don't get panic. No. See, there are certain studies. They have said that bitter and sweet different. जो Huat et al थे, उन्होंने कहा they have observed that bitter and sweet differentiation becomes difficult during COVID. And as compared to common cold, जिसमें कि mostly क्या होता है salt and sweet, this sour sensations, they become compromised. So hypogeusia, like they have some problem, like थोड़ा सा less taste आ रहा है. For some food they are okay, for some food they are. Then ageusia, complete absence of taste. See that I've already talked about कि mild to moderate cases, lesions used to occur during COVID. So many patients, it's my own experience, my family members, they all had, this dysgeusia during COVID. But in severely hospitalized patients, these lesions occurred 7 to 21 days after COVID. So they were secondary lesions, like they were not the primary, like COVID virus was not directly involved in the neuronal damage. It may be because of certain infections, or there may be because of immune weakness, or there may be direct damage to the nerve cells. There may be demyelination of nerve cells, as they say. So secondary lesions were common in severely hospitalized patients. So they may be EB virus or P. intermedia, T. denticulum. They all increase that might lead to taste alterations. Though the theories are there, see, we don't have right now. Literature is actually deficient. We have only case reports. We have only 1 or 2 systematic reviews based on this. But still, as like we are getting more and more patients, we should report this so that if the patient comes with these lesions, they might be slightly aware that they may have the COVID as a latent stage. So if we talk about gustatory disturbances, there are so many mechanisms. I have already talked about like so many things, but they say that if the patient is having taste disorders, that patient and no other symptom, that patient was 6 to 10 times more likely to develop COVID as compared to the other people, okay, who did not have taste disorders. So see, we all know, हम लोग पहले खाने को सूंघते हैं, and whenever there is inflammation of nasal mucosa, rhinitis, there is a local inflammatory response that may also lead to gustatory alteration. See, it's a very important thing. Our brain perceives anosmia and ageusia as common lesion. ठीक है, वो हमें पता चलता है कि हम स्मेल नहीं कर पा रहे या टेस्ट नहीं कर पा रहे, क्योंकि खाने को हम पहले we just take a smell, we breathe the food and then we eat the food. So that might be because of ki rhinitis हो रहा है, local inflammation in the nose is there. That might be one of the reasons that patients are feeling ageusia. There might be severe drug adverse reactions. As I've talked, there may be direct damage because it's a neurotropic virus, right? Cranial and peripheral nerves are getting damaged. We have seen myocarditis cases, right? So cranial and peripheral nerves are getting damaged. There is CNS ischemia, and we all know ACE2 receptors are there on tongue, and so we are, lacking the gustatory sensation. A very important mechanism I came across, that SARS-CoV-2 causes dysregulation of dopamine serotonin pathway. See, they have not explained how it is. They say dopamine serotonin balance is important for taste sensation, but this SARS-CoV-2 has found to be dysregulated this pathway. And they also say that SARS-CoV-2, this Dos Santos et al. Have given many theories. One of them is that SARS-CoV-2 binds with salivary mucin components such as salicylic acid. And salicylic acid is important, otherwise what happens, this salivary mucin components, they are bound to virus, and taste particle degradation is very fast. Like before your nerve catches the taste particle degradation occurs and there is a disturbed gustation. Our own topic, like we have seen severe gingival and periodontal inflammations, enlargements, See, I don't see, there is like everybody will say a lot of local factors are there. That is why inflammation is there. You know, suddenly I feel I have started seeing a lot of aggressive periodontitis cases. Like right now, my institution is a UG institution. We are going for PG again. Like we again are you going for PG this year. So we don't like, I don't have like that much help ki fatafat photos here, but sometimes lot of cases are coming. I was just discussing it yesterday that I was writing ki how many LAP cases we got this month. Like normally in a month, like we get 3 or 4 cases, around 17, 18 cases of LAP we have got this month. So that's, I don't know, sudden rise of severe gingival and periodontal inflammations, enlargements, like unexplained. Local factors hai hi nahi. No hormonal changes, suddenly enlargements are there. So maybe virus, maybe vaccine, I don't know. Or maybe I'm thinking too much, like, but the literature has to, go, we have to search, we have to take scientific help to establish this. This is the photograph, like one of my friends have sent me because they wanted to know what is this. So they had the diagnosis of osteomyelitis, and we all know that बहुत सारे young patients ने आपने सुना होगा कि femur head is getting avascular necrosed, and they are saying that it is because of vaccine or it is because of COVID, because there are thrombotic episodes. Even one of our students is having same symptoms and surgery has been advised for her. So a lot of like blood supply problems. So osteomyelitis, like with there's no only mild caries and you're suddenly getting osteomyelitis, in the necrosis of bone. So all these lesions are becoming very, very common. So mucormycosis, like I'm really scared of this fungus now, because so many cases we have seen, young smiling patients, and they just have toothache, and suddenly you get CT scan done and they have eye involved, they have so much maxilla involved. Some earlier we say there was okay, periapical abscess, but suddenly you see a lot of palatal necrosis. It may be like बहुत सारे theories हैं कि mucormycosis क्यों common हो गया. See, they say it was in uncontrolled diabetic patients, but then few of them didn't have. Then they say the people who took steroids, then they say because of oxygen supply, there was respiratory acidosis. Then there are many patients which didn't have. Then the theory, ticked towards free iron content of the body, serum ferritin. But then not all the patients had. Then it was like tocilizumab is the culprit, but still we are not able to know who was the culprit. But ultimately patient is losing maxilla, patient is losing teeth. So it's very important कि पहले फटाफट patient भी आए हमारे पास, and then we should also be able to do prompt diagnosis. This is like, this reference I have not got anywhere, but what I have seen, we are doing surgeries. हम 7 days पे sutures remove कर रहे हैं, but patient, I'm not happy with the mucosa. See, if I go with the wound healing index, I may have, compromised scores, but suddenly I'm not happy the way gingiva is healing, because we know that 7 to 10 days, they are important for suture removal, because epithelial healing, at least superficial one, there's a continuity of epithelial membrane. But this is own clinical experience that, and not even, one patient, मुझे एक ऐसे लग ही नहीं रहा कि इसे, मुझे लगता है कि क्यों हो रहा है ऐसा, मतलब patient is not healing, like कुछ गलती हुआ सर्जरी में, या ऐसा क्यों है कि gingiva is not healing. I'm not happy with the wound. Normally, patient comes and you're so happy to see, okay, you remove suture, but suddenly you feel that healing is delayed. So I don't have right now reference for that, but maybe we will be reporting, I will start writing, but then I need to know a lot of things, miles to go. It is just that some things we are observing, and that's why I chose this topic. Like at least अगर एक patient भी हमने बचाया या उसके किसी को भी problem से बचाया, तो that's very important if we just see these lesions. And like everybody is talking कि ये lesions vaccination से भी हो सकता है ना, like we all got vaccinated. So almost Indian population is like 70% मुझे लगता है vaccinate हो गया. Like if we see the data, first dose तो काफी लोगों को लग गया. So people say that there are rare neuronal adverse effects of vaccination also. And why vaccination is reacted, like this coronavirus, the spike protein, we are making antibodies against them, but suddenly there is a cross reactivity between beta coronavirus, जो में common cold हो रहा है, या हमारे पहले के भी तो कोरोना वायरसेस है ना, ये तो न्यू है, तो नोवेल कोरोना वायरस नया है ना, बट हमारे पास कुछ ना कुछ तो है ही पहले ऑलरेडी एंटीबॉडीज, they are cross reacting. Then there are like immune dysregulation is causing neuropathies. or it is an interferon related response. Means they say that after vaccination, interferon response becomes hyperactivated, and in the patients who are having interferon stimulated genes in their endothelial cells, they are having severe side effects. See, not all the patients are having side effects. Only few patients, like Guillain-Barré syndrome, it was like only 1 in 1 lakh cases. But why it is happening in them? There might be some genetic predisposition to these viruses, or there's some genetic mechanism. We are still to unfold that mystery. Neurons have abundant ACE2 receptors, we all do. That is why they say that this interferon and T cell, we have talked about naive T cell will go to T helper cell 2 or T helper cell 1 pathway. The T helper cell 1 pathway is responsible for vaccination related side effects. And though there are antibodies also, but this, like most of the T cell response, most of the interferon response is on that arm where the memory cells are there. So they are causing neuronal degenerations. There is a destruction of myelin sheath, maybe because of that, burning sensation in oral cavity, or neuralgias are increasing. I have seen 3 cases of neuralgia for last like around 10 days, 3 cases of neuralgia. So all these, myocarditis, Guillain-Barré, though they are not directly related to our oral cavity, but they may have symptoms like burning sensation in oral cavity. They may have neuralgias, alveolar, inferior alveolar nerve neuralgia, trigeminal neuralgia. We have such lesions reported, but though आजकल बोलते हैं ना, कुछ भी होता है तो लोग बोलते हैं वायरस की वजह से है या वैक्सीन की वजह से है. See, we all are scared. We all have less knowledge about this virus. We are unfolding. बहुत रोज कुछ ना कुछ नया हमें साइंस दे रही है. People are after this virus to stop the deadly effect of this virus, how to control it, how to tame it. Though the herd immunity, I think, has taken over in India, but still the person who gets affected is getting affected. I have seen so many long hauling cases. उनको first उसमें सिर्फ fever आया, but that fever is lingering on till 2.5 months. Khansi नहीं जा रहा है. So all these are like, because this virus is deadly, it is dangerous. We are still to tame this virus, but thanks to vaccine, that we feel that we are safe. Though the side effects are there, but then it is with every therapy, right? No therapy is 100% safe. No therapy, like hepatitis B vaccinations and all, we have to उनमें भी side effects आते हैं, लेकिन maybe कि कभी इतना highlight नहीं हुआ है. People don't know so much about this. But these oral lesions, why this topic was chosen, because I feel the role of dentist is very dental surgeon, role of periodontist is very crucial, because we are observing our tissues very minutely. So to maintain the quality of life of patients, we should know that how these lesions will heal, though it will heal only with the multivitamin therapy or the anti-anesthetic anesthetic gel we will give. But now we have to give triamcinolone or some turmeric component, like certain drugs are there which are proving to be good for these patients. Then prevention of spread of this deadly virus, if we just isolate the patient for 2 days, 3 days, so he may not infect others. And then obviously daily new strains are coming, new challenges, but then medical science is also evolving. So we are together, hand in hand, we will fight this virus, and we are all committed towards the change of quality of life of the patient, which is our responsibility. And so this was the presentation from my side. Thank you so much. These are my references. Most of them are like review of like oral manifestations. They have reported so many case series, and one of them are like possible role of anti-idiotype like Murphy and Longo. Then this article I quoted, there is systematic review by Arbaz et al., where the prevalence of the lesion, we said tongue was the most common. Then fever, interleukin 6 as a pyrogen, it is causing reactions. Then these are other my references. Thank you so much for patient listening, and thank you so much for giving me an opportunity on such a beautiful platform with such knowledgeable people. I may be like, there may be certain things, which I have left, but I'll read more.
Ma'am, not at all. It was a voluminous presentation.
Thank you.
Thank you for that, ma'am. Thank you, Ruchi ma'am, for this informative presentation. I'm sure that each one of us in the audience must have got enlightened through the talk. Much was heard, but little was discussed till now on the impact of COVID-19 on oral tissue. So I really appreciate the efforts taken by you, ma'am, for this descriptive presentation. Really wonderful presentation, ma'am.
Thank you.
Now the forum for discussion. The forum is open
Anybody, any questions, any queries?
I think no questions.
No questions.
Maybe the presentation was too shallow, or maybe like I tried covering a bit. So thank you so much, ma'am. Thank you.
Thank you,
Thank you.
Ruchi ma'am. Thank you, everybody.
Thank you, Ruchi. Thank you, Priyanka.
Have a wonderful
Thank you so
day.
much, ma'am.
Thank you. Good day.
Good day, ma'am.